So I think we should get underway and welcome the participants for this webinar today. I'm Karan McCann, the Scientific Director of the CHO Institute of Musculoskeletal Health and Arthritis, and I'm coming to you today from the traditional and unceded territories of the Squamish, Tsleil-Waututh and Musqueam Nations. And it's really an exciting day for me to have a panel that was conceived by patients and that has got a real patient focus. And I'm going to say that the Institute, IMHA, is very authentic in its patient engagement. And so I want you to benefit from all of that for as much time as possible. So I'll be concise, and it gives me great pleasure to introduce Dr. Dawn Richards to host from here. And Dr. Richards is an organic chemist by training, and then she spends her time in the patient engagement space as a person living with osteoarthritis and rheumatoid arthritis, inflammatory arthritis, and she said that publicly, and I know she was okay for me saying that. And then she also consults in research, and so she's in this lovely space at the intersection of research, patient engagement, and policy, knowledge translation, knowledge mobilisation. And Dawn, it's been a privilege to have you working with the Institute in your role as lead for patient engagement and research ambassadors. So I'll turn it over to you.
Thanks very much, Carm, and hello, everyone. It's my pleasure to be here with our panel today. I'm going to provide some brief introductions to our panelists so that they can just take things away from here. They're each going to present for a few minutes, some with slides, some without slides, and then hopefully we'll have lots of time at the end for questions. So we'd encourage you throughout the webinar to feel free to type questions into the chat that you'd like asked, and we'll do our best to either ask those questions, or maybe we can bucket some of those questions into themes to make sure we get to as many as possible. So I'm going to start out by briefly introducing our guests. So first, I've got Eileen Davidson, and Eileen is coming to us from Vancouver today. She is public about living with rheumatoid arthritis and osteoarthritis. She's a member of the Arthritis Research Canada Patient Advisory Board. She's a member of IMHA's Patient Engagement Research Ambassador. So I have the pleasure of working with Eileen, and you've probably seen some of her writing for Creaky Joints, and she does all kinds of blogs. So welcome, Eileen. Second, we have Dr. David Hunter, and David's coming to us from down under. So it's Tuesday morning for David, and he's a rheumatologist and researcher, so rheumatologist, clinician, researcher, and his primary focus is osteoarthritis. He leads a clinical and research team dedicated to improving the understanding of OA and the quality of life for those who live with this disease. And he's the Florence and Cope Chair of Rheumatology and Professor of Medicine at the University of Sydney and Royal North Shore Hospital. So welcome, David. It's a pleasure to have you here. Next, we have another Hunter. We have Linda Hunter from this side of the hemisphere. So Linda lives in Ottawa, and Linda's public about living with osteoarthritis. Linda is a retired healthcare executive and former ICU nurse, and she lives with chronic pain due to arthritis and other conditions. She's a passionate patient advocate, which you'll hear about today, for patient and family-centered care and patient engagement. And her hopes are that really this leads to change in healthcare practice, policy, and research. And again, I'm very privileged to work with Linda. She's also part of IMHA's Patient Engagement Research Ambassadors. And last but not least, we have another Linda. We have Linda Trung, who's coming to us from Vancouver today. And Linda is a fourth-year PhD candidate at UBC. She's a practicing physiotherapist with more than a decade of clinical experience. And she's going to talk today about some of her research that focuses on social support influences on exercise participation after knee injury. And she's involved in many studies related to OA, including piloting a virtual PT-guided program to help reduce OA risk after sport-related knee injuries. So without further ado, Carm, did you want to introduce any of the learning objectives or should we go straight into things? We're going to go straight into things. Okay, so I'm going to ask Linda Hunter to take the floor and to kind of set us off here. So go ahead, Linda.
Thanks so much, Dawn. Absolute pleasure, and welcome to everyone that is here with us. So I am a retired executive in healthcare. I'm 58 years old, and I've been living with chronic pain for the last 12 plus years or so. I also used to work as a clinical nurse and do a lot of patient advocacy work now. I have a few diagnoses, one of which is obviously osteoarthritis, which I have in my hips, knees, and hands. However, I also live with axial spondyloarthritis. I have spinal stenosis, both congenital and also due to some conditions I have, including degenerative disc disease. And I also live with IBS and endometriosis. And I just bring that up just so that we all know us as patients are so much more than our one diagnosis. It's really a part of us. I want to talk about the challenges I've had in my journey to my diagnosis and also living daily with chronic pain. I also want to talk about some themes and some things that I as a patient would suggest that we could take to heart and have discussions about to improving the system. I'll start by saying the challenge of being a healthcare professional and then being a healthcare professional who lives with a chronic condition can really be quite confusing and complex. And thinking success in one's professional world really equates with, oh, I can't be that sick, I can't be that bad. And fear of losing what you have was really something that I found challenging. If you look good, you really can't be that sick attitude, therefore you don't believe you're sick and you don't necessarily move forward. A lot of my journey through to my diagnosis was, I was in my 40s at the time and it was, oh, it's just aging, there's jokes and messages, you have creaky joints, etc. Who doesn't get like this as we age? We're all living a very stressful life anyway. So because of that, I found sometimes that physical symptoms weren't believed. And especially for my age group, being a woman, being in a stressful job, there was a very large jump quite quickly to a diagnosis of depression. So not being believed when you're talking about your physical symptoms was problematic, and seeing so many people, so many from rheumatology, sports medicine, orthopedic people, neurologists, neurosurgery, etc., it got really quite confusing. In that confusion, I find sometimes there was what I called diagnostic creep and diagnostic confusion. A whole bunch of words were shot at me: lupus, Lyme, rheumatoid arthritis, ulcerative colitis. Oh, we better look at her history of other inflammatory diseases. I was led to believe that I was living with MS for 10 months before I was told that I was not living with MS, and that was absolutely devastating. Then I was told, oh, but you might have ME, chronic fatigue, and maybe fibro, but we can't help you with that. And then you have to move on. So keeping all the tests straight, what different people said to you straight, was really an onerous job for myself to do. I felt sometimes that specialists speak to us as patients as if we're a body part. And I don't say that everyone does this, but there is that implicit kind of feeling that you are the part of the body that that person's looking at. And if that part seemed okay, well, then everything's fine and you just have to go on to someone else. So you really sometimes felt you're a little bit crazy and you had to be your own advocate to move things on. I successfully had a spinal fusion 2 years ago, a double spinal fusion, and I am much more mobile than I was in the past. That's great. However, it did not cure what I live with every day. And I find sometimes people think when you have a surgical correction for something while you're living with chronic pain, that it means that you're cured and you really don't have to be in the system anymore. So there's a lot of troubles with that. I found some of the medication, and I'm a nurse by training, perhaps isn't explained in the side effects as well as it could be, particularly medications like gabapentin and Lyrica, pregabalin, and I found that problematic because I suffered very serious side effects. I find that from that, many of us as patients turn to over-the-counter therapy and perhaps other addictive type of substances to deal with our pain when our pain isn't been dealt with by people that we're going to see to try have a plan put in place. I found sometimes if you're strong and assertive and ask questions and look up and you're looking okay that day, you really can't be believed that you're truly having suffering or having pain because of the way that you're presenting yourself. And even though I worked in healthcare for over 38 years, I found sometimes my peers in healthcare were not as supportive as I felt that they could be towards someone living with a chronic condition. When I look back and I really thought, well, how would I theme some of these things? I think there's a fair bit of ageism that's seen. I think if you're a woman of a certain age and living with stress, there's always going to be that mental health trajectory, which might or might not be true. I find there's a theme sometimes of being ignored and not heard or misinterpreting what someone is saying to you as a patient. And there's not always a real plan that's concrete that you can grasp onto and know about. I found sometimes it was just medicate for whatever is troubling you today and move on post-medication. And I also sometimes felt like I was a hot potato. I was just been tossed to person, physician to physician, because no one really knew what to do. What does work for me as a patient living with osteoarthritis and chronic pain? I'd say the first one, and it seems so simple and it's not, is really listening. Have my GP and specialists listening to me. The way that I can expedite some understanding is having a file. I keep a file folder of everything that's happened, everything that has come forward from tests and imaging and medication, and that allows my healthcare professionals to be as up to date as possible. I try to live in the moment. I try to practice mindfulness, be grateful for what I do have, appreciate nature and beauty around me, including people that I work with. But I choose actively to be positive every day, not Pollyanna-ish, but just choose actively to look for what I can do and not what I can't do. That leads me to suggest that we have to accept our pain while also controlling our pain. And for me, that's exercise and movement, hiking, walking, biking, etc., but also pacing myself. And Linda here with me is a physiotherapist, using physiotherapy specialty services when warranted. I really say that medication that has been a life changer for me has been medically prescribed CBD. And I really don't feel that we speak in this space enough about medications, perhaps out of the ordinary and perhaps that need more research. I find that myself as a patient advocate, since I've been retired, this advocacy and the giving of advocacy has allowed me to really feel that I'm contributing something to this space. Knowing that others, like people on this webinar, are going through the same thing is helpful. However, that being said, there's still many things I think that we could do, and I'd like to offer 3 suggestions for change. The first one is, and I say this with warmth in my heart as a former nurse, when you really think you're listening to someone sitting in front of you as a patient telling their story, as a healthcare professional, please stop, take a deep breath, and then really start listening again. It is so hard to listen, and I think we all think that we do it well. There's those of us that are well, living with chronic illness, and I put myself in that category. And a gap I find in the system is for us, well, chronically ill, is we don't really have an interprofessional clinic whereby we could call someone or email someone or talk to someone about, changes or things we're seeing. And I find when I interact with the system, it's only when something big happens. So I have belonged to different musculoskeletal groups and clinics, but I find that there's a lot of us that are kind of lost between the cracks, just someone making sure year to year that we're doing okay and what changes we might have had. And the third change that I would suggest is that we really need to encourage more patients, those with lived experience, being on boards of healthcare organizations and health professional organizations specifically, not as a token member and not as a board member who also represents being a patient on the side, but we should be chosen as patients to sit in these boards of organizations. Because I really think this would allow for the patient voice and patient co-design related to strategy and policy implementation to be enacted. And I believe that that would be very powerful. That being said, I will close with saying, I'm still my #1 advocate for making myself as well as I can be. And I don't mind doing that, but I'll tell you, and I'll tell my health professionals, it is absolutely exhausting at times. So thank you for listening, and I really look forward to the discussion that we're going to be having. Thanks, Dawn.
Thanks, Linda. You've kicked things off really nicely. My head is swirling with all kinds of ideas that you're giving the audience about some of your own experiences. So thank you very much for that. Next, we're going to move on to Eileen. So over to you, Eileen.
Hi, wow, it's very difficult to follow up, Linda. That was incredibly powerful. And so much of what you have said, I see a lot in my story as well. I wanted to talk about my rheumatoid arthritis diagnosis and how difficult it was going through that as somebody who wasn't even 30 yet. I was diagnosed with arthritis before I even had gray hairs or wrinkles. I didn't even know I could get arthritis at that point. So I had to come from not somebody in a scientific background or as a medical background. All of a sudden now living with a chronic illness, how was I going to figure this out? But I'm going to walk you through how difficult it was to actually get my diagnosis. And part of that was because I was so young and because I looked fine. My symptoms began around age 24. I was working as an esthetician. So if you know what that is, that's somebody who does a lot of massage or is hunched over somebody's feet, kind of things like that. So I had body pain from that, obviously. But every time I brought it up to my doctors, they said, oh, it's your job. Maybe don't do massage, wear a wrist brace, rest, it will go away. And this went on for a couple of years and it started to kind of migrate or the pain just got worse. I stopped doing massage. I asked different places that I worked, can I not do massage? Or can I lighten my workload? And even still, that didn't help. But then when I was a month shy of my 27th birthday, that's when I had my son. And the last trimester of my pregnancy, I swelled up really, really bad. And I had extreme fatigue. And I remember catching all the infections. And I had a really hard time during my pregnancy. I figured, okay, well, all of this is going to end once I have my child. So I had my child and none of it ended. In fact, a lot of the swelling stayed, the fatigue stayed, the pain definitely stayed, and it migrated into places like my hand, not even just my hands, but my elbows, my shoulders, my feet, my knees. And I was also really, really just tired all the time. It didn't seem like no matter how much coffee I drank, nothing would wake me up. I could drink 3 Red Bulls and still probably have a nap. And I was consistently sick. So I was off work for a year for maternity leave, and none of this got better. Then I started to blame myself. I thought, well, you know what? I put on weight during my pregnancy. I just need to exercise, or, you know, I'm just going through postpartum depression. So I'm just doing this to myself, or I'm spending too much time on the computer. And when I brought this up to healthcare providers, many times they said the same thing. Oh, just be more active. Don't be so hard on yourself. Oh, but you look great at the same time. And so I left very, very confused a lot. And I was just trying to wonder, like, well, I don't feel like this is carpal tunnel. Why can I not wear my shoes anymore? Why am I feeling so bad? So, and it was at the point where the pain and everything was so bad to the point that I would go into work and I would do one service, pedicure, or even an eyebrow wax. And I would be in so much pain and in the back room in tears because I couldn't handle anymore. And this is when I said, okay, I need to ask my doctor. And it took so much out of me to just ask this family physician who would help me with my pregnancy for investigating what was actually going on, because I was consistently told, you know, this is just carpal tunnel, and I never really felt heard, and I didn't know how to bring up my mental health. I was really kind of struggling with how to bring up the mental health aspect that I was going through as well. And so at this point where I could no longer work, and I have a family history of rheumatoid arthritis. So this is one of the reasons why I said, okay, I'm going to go into the family physician and I'm going to say, test me for rheumatoid arthritis. I have an aunt who has RA. So I'm wondering if the family history would mean they would actually run the test, because it seems like before with the carpal tunnel, nobody wanted to run any tests. In fact, actually, nobody even looked at my hands or did any examinations. They just assumed that I had carpal tunnel because of my age and my job. Well, my family physician, when I asked her for that rheumatoid arthritis test, she looks at me and she goes, you don't really have any visible swelling. You look great, maybe fibromyalgia. And at that point I felt, well, are you sure? I still wanted the test. And 3 weeks later, I was diagnosed with rheumatoid arthritis, and that's when my entire world was flipped upside down. Now I had to learn what really rheumatoid arthritis was, this autoimmune disease. And I had to learn that arthritis was actually an autoimmune disease. I remember making my rheumatologist test me for everything else. I was saying to her, you know what, this doesn't make any sense. Especially when people were also saying to me things like, you're fine, you're young, it's just arthritis. Oh, try turmeric, or just exercise some more, do some yoga. Oh, I know somebody who cured this through some whatever wacky thing that we are recommended. And so I just remember for the first few years of my diagnosis, trying to go through the grieving process, as well as trying to navigate how to be a single mother at this point with my chronic illness, as well as trying to learn how to communicate with doctors as specialists. I've never done this before. And I think for the first few years, I really didn't understand. It was like speaking a different language to my rheumatologist. What were these blood work they were talking about? What is an autoimmune disease? What does this mean that I'm at high risk for infections? What do you mean these medications I need to watch out for even if I get a simple cold? And what do you mean like exercise is going to help me when I'm in so much pain? And trying to vocalize what I was really going through and how it was affecting my life. I remember just breaking down into her office, my rheumatologist's office one day, and she kind of looks at me and she goes, this is very clearly affecting your mental health. And I think right then and there, when she saw that it was affecting me more than just my joints being sore and it was more than arthritis to me, she's like, you know, I'm going to send you to the Mary Pack Arthritis Center. And that's where it opened up a whole new door to me to learn how to live with this disease. I got to see an occupational therapist. I got to see physiotherapists. I got to attend these classes put on by the Arthritis Society with other occupational therapists, PTs, and then seeing a social worker and just being able to talk about all what I was going through and making sense of what I was going through. And then I started to actually be able to pick up the language of living with a chronic illness, especially when I discovered what I find really, really useful was also finding online support groups. Particularly my favorite is Rheumatoid Arthritis Canada on Facebook. I think I jumped for joy when I found other Canadians that I could talk to, and or even just be a lurker on the internet and reading their stories or their questions. And being part of these groups was a way for me to develop questions that I didn't even know I had to ask my rheumatologist by just watching what other people were saying or reading the comments that people were saying and saying, oh, my rheumatologist was saying the same thing. So that, okay, this is making more sense. And especially when hearing patients say it, where we feel sometimes rheumatologists might speak a little too scientific for us. So when I was listening to other patients say it, it was now put into plain language for me, and I could easily start to understand it. And so at that point, I started to feel like I had a grasp on starting living with this condition and finding resources online that are medically accurate, like Healthline or Creaky Joints or the Arthritis Society helped tremendously as well. But still, I may be able to communicate better with my rheumatologist and that way, but it's still a difficult battle to try and communicate with other healthcare providers that are not trained in arthritis. I've had difficulties communicating with gynecologists or, massage therapists, and it's kind of taught me to ask my rheumatologist to send me to somebody who she knows that has a better understanding of RA, because I feel like rheumatoid arthritis affects so much of my health, not just my joints, that I need to consider it in everything else I do with my health.
Thanks, Eileen. I think you brought some amazing messages about communication, about community, I know at the end we're going to talk about credible resources, and you brought some of that in too, with everyone having ideas for you about how you're supposed to magically cure yourself with diet or whatever it is. So thanks very much, Eileen. You've given us also great food for thought. Next, we're going to go on to Linda Trung. So Linda, take it away for a few minutes here.
I'm just going to share my slides here.
Perfect.
There you go. And thank you, Linda and Eileen, just for sharing your story. Like, I think people are making comments, just your stories are so powerful. And I think for me as a physiotherapist, it's really what drove me to do research as well. Just how to make your journey a little bit more smoother, or how do we just come alongside your journey and just be better supporters. And so I'm going to talk a little bit of social support. And so a lot of the patients that I've worked with are individuals who had traumatic knee injuries, so anterior cruciate ligament or ACL injuries. And oftentimes these patients are at greater risk of developing osteoarthritis, which I think is why I had a vested interest in looking at this. And I also got to treat and manage patients with knee osteoarthritis. So that's where I'm going to draw a lot of my experience from. And so when someone comes in with an injury or diagnosed with any chronic condition or arthritis, as a clinician, as a patient, we often think the journey is going to be very linear. And I kind of had this mentality for a long time as well when I was practicing. But as Eileen and both Linda mentioned, it's not very smooth. There's ups and downs. There's a lot of setbacks. There's maybe surgery involved, and there's a lot of frustration. So what can we do to help smooth this journey or make it more enjoyable if we can? And that was kind of the driving for me to go back into research and kind of explore this question. And I think this is where we can leverage social support. And I think both Linda and Eileen kind of mentioned this a little bit. And while social support means different things to people, as a physiotherapist, this is actually really the one-on-one relationship that we create with our patient. And something that it's really challenged me was learning to build an actual strong relationship. And we've heard it over and over in both Eileen and Linda's story about being heard and like actually listening to your patients. And if we're trying to shift towards more what we call this patient-centered care model, we can't really do this without building a trusting relationship with our patients. And so for me, that meant really shifting how I approach clinical care. And so I had to shift to create more time for my patients and not try to manage 3 to 4 patients at once. And so I just think that we can't really help our patients feel in control if we are not giving them time. I think it's also thinking outside the box, looking at our patients' social networks or communities, and this may be virtual or this may be in person, but looking at, are there ways that we can connect people with who are going through similar journeys? Because we know in the research, as well as through my experience, there's power in sharing people's journeys together. And so I think, with Eileen and her blog, that's a resource for people to come and learn if they're going through a similar journey. But I just think that there's this hunger and desire to try to connect with other people who are experiencing some of the things. And because for me, I spent a lot of time running group exercise classes or group rehabilitation. I just wanted to talk about that because that experience has really taught me that just this environment has really helped to also foster patients learn to take a little bit more control or building autonomy. And I want to share about that. And so I ran a group class back in Alberta for people with traumatic knee injuries. And again, we are hearing this message about when you have an injury or arthritis, it's not just about a body part, it really affects your life. And I think when you are trying to get people to exercise, because we know that exercise is an important management of any chronic disease as well as injuries, it's not that easy. And so group rehabilitation really helps to get people to exercise together. I think is really inspirational. For me, it's helped create a safe environment for a lot of patients to exercise. Linda mentioned about pacing and like, how do you know the limits of what's safe to do, how much you can push yourself when you're dealing with pain? And I think that this group environment really helped to start to create some of these boundaries. I often hear a lot of times frustration from my patients about getting so much different messages, like what I can do, what should I do, different diagnoses. And I think by getting to work with my patients consistently in this group environment, we're able to kind of draw on what's the evidence, as well as give them consistent messaging. And I think that eases a lot of the frustration or a little bit of the guessing work. And again, because group rehabilitation is a social thing, I think just exercising with other people, there's just power in that. It's inspirational, but it's been amazing to get people who are like 14 to 15 years old. Maybe they just injured their knee trying to go back to sport, but they're also in a class with someone who has osteoarthritis or who just had a total knee replacement, and they're in the class just to get stronger. And when you put all these individuals together, it's actually like a really fun and different dynamic. We've had a gentleman who was 60 years old who had osteoarthritis, and he was actually lifting way heavier than some of the kids who were like 15 or 16 or 20. And it was just so amazing to see that. It debunks a lot of the myths around age where you can't do certain things as you're older. Or I think for our younger generation, they started asking questions about, well, what is osteoarthritis? And showing that they do care about this even though they're really young, and helping them to kind of understand potentially managing their risks at an early age. Because we keep talking about this relationship and really being heard, I think when you work with someone consistently, I was able just to build a better relationship. I find when I was able to see them like more consistently in this environment, and that really helped me to work with them to promote a little bit more autonomy and help them to feel more control. So they started actually dictating a little bit what they can and can't do. They actually became more vocal and were like, I don't want to try this. I don't feel safe. And I think for me as a clinician, just letting me learn to let go of what, we're domain experts, but really understand that patients actually know their bodies better than we do. And I think that environment's really what taught me a lot of this. And again, I think it's fun, and obviously a journey of whether you have arthritis or traumatic knee injury is not going to be easy. And so if we can make it a little bit more enjoyable or ease some of the stress and anxiety around the injury, why not look at other avenues to help? And so I was really lucky that I'm working part of a project called the Stop Osteoarthritis project with Dr. Jackie Whitaker. And this is a virtual program that is exercise focused, led by physiotherapists. And we integrated group exercise classes. And what's interesting is that our intervention, we purposely try to remove the expert role. So the physiotherapist is involved, but it's more of a partnership between the physio and the participant, and really trying to work together to co-design exercise goals. And one of the cool things we're seeing is that all the benefits that we are seeing in in-person group rehabilitation is also kind of being reported virtually, as well as like people are actually appreciating this approach of kind of letting them be in control. And like again, coming alongside their journey and being more of a partner versus a dictator. And even though it's really different for them, even the young generation is saying, or the young participants in our study are kind of saying that, it's a nice way to help them kind of regain the control of maybe their OA risk. And so my takeaway solution, so just food for thought, is like, we really got to emphasize that therapeutic relationship. And if our goal as clinician is really trying to push towards more of a patient-centered model, we have to really work on building this relationship and treating the patient as a person versus just like an ACL injury or like a person with osteoarthritis. I think, again, thinking outside the box. So how do we leverage maybe people's social networks? We're hearing, Facebook groups, Reddit forums, other resources that patients can tap into, because there is this power in sharing the experience. I've had young patients go on Instagram and meet other people with knee injuries and just telling me how powerful it was. That was how they actually were able to cope with their injuries, just finding someone with a similar injury. And I obviously have a big bias towards group rehabilitation. I would love to see that more, not just in knee injuries or osteoarthritis, but also just in all different conditions, because I think there is a value in having that. And I would love to see that a little bit more in clinical practice. And so those are kind of the three things that I've learned, as well as food for thought later when we kind of have our discussion. Thank you.
Thanks, Linda. So many gems there. I took away patients know their body better than we do. Check. I love the part about being a partner versus a dictator and letting them be more in control. And then this idea of the power and sharing experience, which I think is a big part of today's webinar. So thanks very much, Linda. And David, last but not least, over to you for a few slides from your perspective. I think you're on mute, David.
It's a great privilege to be here, and really appreciate the opportunity to speak on this wonderful panel, and particularly after those powerful stories that Linda and Eileen mentioned, and obviously great insights from Linda Trung as well. So thank you very much for sharing all of that. I'm going to speak a little bit, hopefully from a perspective of a clinician, someone who's had the privilege of looking after many patients over a long period of time, and hopefully give you some insights from my perspective, speaking, I guess, both to people who have that lived experience with disease, but also hopefully a few tips if there are any clinicians online for clinicians caring for people with arthritis as well. And again, just to really echo the power that those stories encaptured, and to say how privileged I feel to be part of this panel. I come from a different part of the world, and I would just like to start by acknowledging our traditional custodians, and particularly the Camaragal people of the Eora Nation, and pay my respect to elders past, present, and emerging. Just by way of disclosure, most of my support comes from the National Health and Medical Research Council in Australia and Arthritis Australia. And I also want to start by disclosing that I am far from perfect. And I really want to appreciate the contributions from a number of colleagues and their work that they've contributed to these slides, particularly Shannon Miyoko from Wake Forest University, Sam Bunsley from University of Melbourne, and two of my PhD students, Vicky Duong, who's originally actually from Toronto, and Naomi Simic. And this is just a quick outline of what I'm going to go through, just I guess briefly to look at the way we currently communicate and ways that we could improve that, to look at ways that we might be able to get a more successful clinical encounter, to look at strategies that might improve the status quo, and then really looking forward to the interaction towards the end and your questions. And this all starts from a premise, a foundation, where we know that very few of our patients are actually satisfied with the treatment that they're receiving. And in general terms, about a third of people are satisfied. So there's great room for improvement. And to me, that starts with trying to understand what is wrong, and also about how we best communicate this. We know that at present, terms in osteoarthritis like wear and tear and bone on bone give people the perception that they have a vulnerable joint, and oftentimes as a consequence of that, they avoid activity and think that surgery is the only option and that deterioration is just a one-way street. And that type of discourse is what we tend to frame as an impairment discourse. And again, these are some quotes from patients about their experiences with healthcare professionals and the language that gets used, particularly that bone-on-bone concept, but essentially communication that tells a person that their joint is no longer good for activity, as opposed to what we'd ideally like to be trying to encourage as a participatory discourse, and to build a sense of trust with the health professional, to know that for most people, the joint is still sustaining mobility and capable of load, and that they've got much greater control if they have that empowering type attitude. Now, I know for many of you, you've probably been through a discourse that is consistent with what we're calling the impairment discourse, whether it be thinking about the body as a machine, and Linda Trung mentioned this sort of biomedical type model, and that we probably need a mechanical problem, a mechanical fix, and overall there's this downhill trajectory. And so this is really disempowering, I think, for most people who are out there, as distinct from the more participatory discourse and healthy aging and empowerment, where you own your knee, you maintain it, and hopefully through treatment, you prevent its progression, and that you're in charge and the clinician can aid and guide through that process. But ultimately, it's about empowering you. Some of that can come about through a process we call motivational interviewing. And I'm just going to run through, I guess, the schema, which is about having very open-ended questions, affirmations of your experiences, reflecting carefully and listening to the story, and summarizing. And these are some questions that may prompt that open listening style of motivational interviewing. And for those of you that would like to learn a little bit more, this is a podcast we did recently with a wonderful nurse, Julie Leask, who's very big in the vaccination space, but really taught us a lot about that motivational interviewing, particularly from a vaccine hesitancy perspective, but as it's applied to arthritis. So how can you, as someone who has arthritis, increase the chance of you having a successful clinical encounter? Well, in the first instance, you need to empower yourself, be informed or educated, be motivated. Ideally, prepare questions in advance, and if appropriate, just write them down so that you do ask them at the time. Try to build long-term clinician relationships and make sure that that is working for you. Ideally, have a one-page history document that you can bring to new encounters that summarizes the journey that you've been on, because that will definitely help to encapsulate a lot of information that you then don't necessarily have to repeat on a regular basis. And as Linda Trung was just mentioning, care coordination and integration of care is critical. So if I look at the osteoarthritis treatment paradigms here of typical issues that are faced by a person that has osteoarthritis, we know that interventions on those are likely going to require a range of different healthcare professionals, whether that be, an exercise physiologist, a dietitian, counselor, orthotist, and so on. So it's really important, ideally, that care be as integrated and coordinated as possible, so you don't walk away with too many conflicting messages. How do you know what to look for in a healthcare professional that hopefully is providing more holistic care? In an ideal world, they're not using that biomedical approach, but rather a biopsychosocial approach, that they're happy to work with different disciplines, recognizing that they don't necessarily have all of the answers and all of the tools that will help you on your journey. Ideally, that this be about you and that it be driven by you, and that whatever they try to do be measurable and be capable of monitoring. And so this is overly complex, and I apologize for that, but these are some of the aspects of holistic assessment of a person who has osteoarthritis, and some of the things that oftentimes get ignored, and oftentimes, unfortunately, to the detriment of care. We know that ultimately, you as the person who has arthritis is at the center of care. And as clinicians, hopefully we can help to identify what risk factors you have that are modifiable and give you skills and self-management techniques, because this is largely about you helping to manage your own disease, that will ultimately help to target each of those modifiable risk factors. I'm going to skip through some of these because these are probably more directed to clinicians, but just some practical suggestions on how to maintain adherence and techniques to improve self-monitoring of behaviors, because self-management and you being empowered to manage your own disease is critical in this journal. And as clinicians, we're there to help and hopefully facilitate some of the changes in behavior that long-term will assist in disease management. Again, apologize for the busyness of that slide, but again, hopefully some tips that might be helpful for any clinicians who are out there. But just want to emphasize the first one, and that being about setting really clear, specific, and challenging goals for behavioral change, and updating them over time as the patient and the person who has that lived experience gets better. This is probably more important for you. I know many of you rely on Dr. Google and other sources for information, and it's really critical for you to recognize what might not be helpful and what might be misinforming you with regards to your care. This is Christian Barton from La Trobe University in Melbourne. He's a wonderful proponent of empowering people and educating and translating care. And so these are some tips from Christian about how to recognize misinformation in digital and social media. If it sounds too easy and too good to be true, it probably is. If the health information is being provided by a credible source, that's a good start. Does the expert providing the information have a conflict of interest? Sometimes that's hard to dig out, but it's important to recognize that everybody, myself included, potentially receives funding from different bodies that might influence what we're saying. Hopefully it's not coming through in today's presentation. How strong is the evidence to support the claims being made? Is the information based on anecdote or individual causes? And is the new research reflective of correlation or causation? knowing full well that this is much more powerful. All right, so where can we go to from here? And, recognizing that a lot of what currently happens in clinical practice with regards to empowering patients is not optimal. In an ideal world, we'd move from a model, which is currently what's taught in most medical and health professional programs around traditional patient education, to one that looks more at self-management education and give you the skills to overcome problems, and not necessarily just focus on the disease, but rather identify the problems that you're experiencing and give you suggestions to help you deal with those issues. It's not easy. And I recognize that I fail in many instances in this regard, but ultimately, I think this is the direction we need to shift our medical and health professional education in order to better empower you on the journeys that you're experiencing. And as mentioned, this is the traditional education module. And ideally, we're trying to shift towards this more empowerment-based communication model, where this is much more biomedical and doesn't take into account your life, really. Oftentimes the depression, stress, anxiety, socioeconomic challenges, problems that you're having in your own environment. So we need to shift our education so that we go from what is currently our traditional education model to one where we can hopefully empower you, and ultimately empower you to make more informed choices, live your life better, and change that journey to be a more positive one. One of the things we're doing in this space is developing this massive open online course targeted towards what we see as core capabilities for healthcare professionals, and hopefully doing this in a way that encaptures some of that empowering participatory discourse that I was talking to before. For those of you that want a little bit more information, I just point you towards the Joint Action podcast, and in particular, this episode from Sam Bunsley, which she really talks about that the different types of discourse that are available and how powerful words and communication can be in letting you live your life as well as you can. So I'm going to close there. And again, thank you very much for the opportunity. Again, I'm talking with my osteoarthritis lens on, and encourage hopefully many of you who are out there to have more participatory communication, motivational interviewing, and an empowering journey to help you to live with your disease. I'd like to thank my team, and again, thank you for the privilege to speak with you today. I'll stop sharing and pass it back to you. Thanks so much, Dawn.
Great. Thanks a lot, David. I mean, you had me at Shift Education to Empower Patients in Their Lives. Tons of good messages in your slides there. I think one question I would like to ask everyone is if you can share an experience of what you came away feeling like was a really great clinical encounter, or really good, either with a physician or an occupational therapist, a physiotherapist, whoever, and what made it for you a good encounter. And I don't know if it was your behaviors, their behaviors, but perhaps if we could start by sharing, that would be a good way to kick off the Q&A. So any takers to go first here? Maybe I'll ask Linda. I'm going to ask Eileen because I just saw you come off, and then I'll go to one of the Lindas.
I wanted to jump in on that one because that's definitely a loaded question, and something I kind of, I think of sometimes what does make a good healthcare provider or a good doctor visit. And I really think it comes down to, did they listen to my concerns? Did they not cut me off when I was trying to talk to them? Did they validate or reflect what I was saying back to me? And did they admit when they didn't know what to do next, or if they needed to hand me off to someone? That's okay in my mind, rather than just brushing me off and telling me there's nothing I can do, but to further investigate and find out what's going on. And I know that's not singling one, but when you're chronically ill and go to so many doctor appointments, it's really hard to single it into one appointment. So I think anything that involves them listening, reflecting what I've said, and then if they don't know what to do next, to help me further investigate.
Thanks, Eileen. That's great. Linda Hunter, would you like to go?
Sure. And I'm glad you did something kind of more general with ideas there, Eileen, and kind of broke it up that way. Because I remember one very specific incident about 4.5 years ago. It was a sports medicine physician. She was a medical physician, and she had gone over and worked in the London Olympics. And I knew she was well known, lovely, lovely lady. I was at the end of my wits with pain, and I really didn't know. And there's always a step ladder approach, to diagnosis and also to going to get different treatments and modalities to help with your pain. And I was at the end of my wits. I couldn't walk more than 10 meters. I was in pain so much, and I was trying everything to control it. She sat down with me and kind of explained some things. And then at one point, I just started crying uncontrollably. And sometimes people say, oh, female, particular age, this is what you're doing. But I learned something today from one of my peers in a patient advocacy group, and it's a word on self-stigma. And self-stigma definition is being uncomfortable to talk about where we are, what we're experiencing and feeling because of how we think of ourselves or those around us. And I saw this in myself as thinking I always had to make sure that I looked like I was okay and that everything was okay, so that when my physician group or my health practitioners were speaking to me, I was under control. And I have learned that I have to let go and let my honest feelings come out in dealings with particular people to let them know how bad things are. So when I let myself cry and said, I just do not know what I can do with this pain anymore, I am at the end of my wits, I can't even sleep, she stopped talking, and she put her hands very gently in my knee and said, I will do everything I can to support you, Linda. And that hit home. She was truly listening, and she wasn't trying to figure something out and give me a solution. All she wanted to hear was my experience, and I felt validated. It was very, very strong, and I remember it to this day.
Thanks, Linda. So a pretty strong theme there of simply being, this sounds horrible, but simply being listened to and acknowledged. So I'm going to see if David or Linda from the clinician perspective would like to offer any of their experiences as well.
Yeah, so for a clinician, I think it's always challenging when you have also just being more transparent, because I think sometimes we're taught to be, you want to be present, but you don't want to show your emotions as well. And I don't know how you can go through someone's journey without actually being in that moment with them. And so I had a young patient who had a traumatic knee injury just a couple months ago, and she started crying in the clinic. And initially my first few years of practice, you instantly are trying to give them solutions. Oh, it's going to be okay. We're just going to work through this. And I just sat there with her, and I was like, pardon my language, I'm like, yeah, this is just a city situation. Like, this sucks. And then that was what she needed. Like, everyone's trying to tell her, all you got to do is work hard and you'll be fine. But right now she doesn't feel fine. And she just needed someone to say, nothing's fine right now. And just to acknowledge I'm going through this. And so we just sat there in silence, and she needed that time to just kind of absorb what's happening versus here are A, B, C, D, E. This is all the next steps you need to take. And I don't think if I didn't have that moment to just listen and be with her in that moment, we would never have been able to build that relationship to start actually working together to get her where she is now. But it took a long time for me because it's so uncomfortable. So you kind of just want to brush it off and move on to the next step. But I think really trying to put away your laptop, not always typing, and just let yourself be in the moment, I think is the key thing that as a clinician, I've been learning.
Yeah, I mean, and again, I'm far from perfect in this regard, but I think the key message that I'm hearing from everybody is, and the most important message is, to be honest, is to listen, to reflect, to hear what is most problematic, most troubling for people, and to understand what it is that they'd like to be able to achieve, what their goals are, what it is that they're missing out on by virtue of the experience that they're having. And every time I'm in clinic, that's what I do every day. Or at least I try to do every day. But again, a bit far from being perfect, but I think that's what we all try to emulate. And if that's not the experience you're getting, you're not being listened to, if you don't think the challenges that you're experiencing are resonating, being heard, and being acted upon, then say that. And if it doesn't get a response, potentially find an alternate person to have that conversation with.
Thanks, David. Karim, over to you.
Okay, and I've got a question from Laurie Prell. Sorry about that on yours, Laurie. Thanks so much, Laurie Prell. And you popped into the chat saying that you feel so much has to change to truly empower and support patients. And we can have you expand on that if you want to pop in and discuss after, but let's go to the panelists. So you say, I feel so much has to change to truly empower and support patients. And what can we do as a community to support patients' empowerment and the culture shifts? I think we've got this diverse community here today. So I'll look for a physical show of hands for the panelists who wants to go first on that one, and we'll have a few folks comment. Okay, Linda, please.
Sure, I'll go first. Thanks so much for that. And Laurie, I really appreciate it. I think there's multifocal change that has to occur. And I would suggest, I mean, I got trained in nursing, over 35, 38 years ago, but I still think, and I see some in the chat, some others think, I think we have to do a bit of a better job in training healthcare professionals, physicians, nurses, physiotherapists, and other allied health, how to truly do that communication, listening, patient empowerment, partnering with your patient part. As a patient engagement research ambassador with CIHR, I'm also learning that we have to do more training with patients. So patient groups, how do we go through and get the information out to patient groups about what that looks like, about advocating for yourself, about being, assertive without being aggressive, etc. I just think there's a lot of different ways that we can use educational tactics as building blocks and how better to work together. And I think there's different modalities and associations and whatnot out there that we can use to help that happen.
And I thought I saw your hand up going, David, for that question. Yep, go ahead.
Thanks, Karam. Yeah, it's a great and important question. I fully agree with Linda, great last name, is that it's got to start with education, and that's both around healthcare professionals, but I think also for people who have that lived experience with disease, I think trying to give them information about how best to frame communication in a way that's likely to be most empowering and productive for you. I think the other thing that I guess like to say is that there are some shifts in medicine that are going on that I hope will carry through to better quality care. And to me, that starts with communication and the experience that you have when you go in to seek healthcare. And that's around, and this is challenging for the healthcare professionals, but that's around rating the experience that you get and doing that on websites, but also hopefully in time, the way clinicians are actually reimbursed will be based around quality rather than just about quantity, which is what it's currently structured towards. And so that way, hopefully the quality of the interactions that you experience will actually improve.
Okay, great. Thanks, David and Linda. We have some Q&As coming in. So I think Carmen and I are hoping, and I'm just going to put this out there, are people okay to go 10 past the hour so we can get in a few more questions? And we fully realize some people will have to drop, so that's okay if that's the case. Kind of keeping in this theme of communication, and Linda, you talked about this being seen as, you want to stand up and advocate for yourself, but you don't want to come across as too aggressive. You want like the right mix of being assertive. And there's a question in the chat. I'm not sure if there's anything available out there in terms of educational resources. Maybe that's something that David, you would know about. But I guess I'll just put it out to the panel about, what you've seen that's, I guess, come across with that kind of right balance of asking questions, but not having you get your back up against the wall or your provider's back up against the wall, and just generally framing things. Any tips or thoughts on resources related to that?
I don't have actual resources, Dawn, that spring to mind. There might be some out there, including in Canada. Sorry, David, if you were just off, I'm going to say something. I will say that a life lesson for all of us, whether we're a clinician or a patient, is to understand when people are so beyond frustrated, whatever they're going through, they can come across in a very negative manner as a patient. And then how do we as a patient understand that what we're coming across to try to explain our story might be viewed defensively by the healthcare professional that's trying to help us? And then as a healthcare professional, realize when people are at the end of the rope, they're not their real self anymore. They're trying to do anything and everything to be heard. So I think a little bit of understanding kindness in each side helps us all to appreciate that, both from the health clinician perspective and also the patient perspective. And I think we can both probably do a better job at that.
So yeah, I mean, really just to echo what Linda was saying there, I think from the perspective of framing the communication and starting out, is just be well informed before you go there. Be very clear about what it is that you'd like to try to achieve from that encounter. And hopefully from there, the proposals that you have for the healthcare professional to help you with that journey will be framed in a very constructive way. But I think start with some information on your part. There's some great resources that are out there, some of which we've spoken about today, but try to get as well informed as you can so that way when you start to ask those questions, they're as well informed as they can be.
Thanks, David. Eileen, you've got something you'd like to add here too.
Yeah, I did touch a little bit about this in my little chat there, but being a part of groups where other patients are asking questions that maybe you don't realize you need to ask is a great way to kind of develop some questions you can have before consulting with your rheumatologist or family physician. But also Creaky Joints or Health Central or Healthline, they do have articles where you can look at the top questions to ask your rheumatologist at your appointment and help you with plain language on how to ask those and to kind of ahead of time understand what they may be saying to you. So it's just finding those right resources and doing some planning ahead of time, writing out what you want to say. So one, you don't jumble your words, you forget, or it comes off aggressive because maybe you're just not clicking with your rheumatologist that day.
Thanks, Eileen.
So we got one upvoted in the question and answer, and you can see all the questions there. But Nijat Hassan, and it's great to see you, Nijat, asked the question saying, specifically naming Linda and congratulating the whole panelists. But in the context of NEOA, educating young kids about OA after a sports injury, and this is very relevant, sports injuries are prevalent. And then there's this thing about accelerated arthritis after a sports injury. And so Nijat asks, if the clinician talks about you'll have a disease, is that scary? And could that exacerbate fear? So I'll hand it over to you, Linda Trung, please.
Thanks, and I replied in there, but I'll say it out loud. So some of the qualitative we did actually didn't show that. They actually wanted to know more about that, their OA risks, whether or not that knowledge changed their future behavior, that's maybe different, but they actually appreciate knowing that they are potentially at risk for developing osteoarthritis. But I think it ties into what David said, it's how you frame it. So if you're kind of saying, I've been in surgical consults where they're like, if you have another knee injury, your knee is going to be destroyed. You're never going to be able to walk by the time you're 30. And you're saying things like that. You're just really inducing fear to the point where they're never going to want to be physically active. But we know that people with traumatic knee injuries, not everyone's going to develop osteoarthritis. We know that there are things they can do to modify their risk. And if you frame it in a way where they have control, they all, I find, interpret it very differently then. And again, I think they want to know this. Like in our current study, we have an hour about education on osteoarthritis. And when we did interviews, all the young participants said, like, flat out, they were left in the dark. They were like, why didn't I know about this? No one told me about this. And they're 18, 19, 20, and they actually all really valued knowing about that. Because then they said, and one of them actually said, I feel more in control now. Like now there's little things I can do now that I'm 19 years old so that maybe I can reduce my risk. And so I think that myth around young kids don't really want to know about it or we're going to scare them is not true. But I also think we got to be careful how we say and not really freak them out. I think there are ways we can engage them in this conversation. But again, moving our language towards really just being so biomedical and like wear and tear, but words that are actually like everyone's saying, more empowering, is how we need to kind of educate these young patients.
And thanks for that, Linda. And I'm going to throw a follow-up question to Linda Hunter and Eileen Davidson on this one, because David Hunter sort of alluded to this in his words already. I'm not cutting you out of this, but let's go to Linda Hunter and Eileen Davidson first about labels, because that's what you're speaking about. And I think the question is suggesting labels can be harmful, and you're saying labels can also help inform. So, out of Linda and Eileen, who wants to go first on commenting on this idea of labels and the potential risks and the harms and the nuance in language that Linda has taken us towards?
I can take a first crack from my perspective. Labels are only harmful when they define the person in a kind of negative, cursory fashion. And I'll give an example. If someone's living with dementia, it's not a demented person, or the person with diabetes. So I think labels, depending on whether it's an emotion, whether it's a characteristic, whether it's a disease, or whether it's something that might happen, as long as that doesn't define the person, it's okay. When you were having this discussion, Linda, and then Dr. Khan, when you put it forward, I would suggest the biggest word that's of importance to me with labels is hope. We can never take hope away from people. So don't define someone as their label. A patient is a person with many lived experiences that surround them, including their intellect, their social structure, their family, their positive experiences, and they want to be the best person they can be. I want to be the best Linda Hunter I can be. So always give me hope, but make sure that it's realistically defined quantitatively and qualitatively, but ask me what that hope means to me with whatever label of diagnosis or condition or thing that might happen. That's kind of the way that I look at it.
Eileen, go for it.
I've been asked that question a few times, if labels or being called a patient bothers me. And I guess reflecting much like what Linda said, it only bothers me when I can tell the person only views me as that label. They don't see me as anything else. And that definitely reflects in when I'm reaching or seeking out for care, because I can tell a good healthcare profession is going to be asking me about my goals, what I want to achieve, rather than just saying, oh, this is a patient who needs a medication, bye. So yeah, it's seeing me more than a patient, and seeing that there's layers to these labels.
Thanks a lot, Linda and Eileen. There's another question in the chat that's about meds and knowing when it might be time to change meds, but I'm gonna broaden it beyond meds, and that the other therapies that you're using, or maybe some of your other experiences when things just either as a patient or as a clinician, you've noticed that it might be time to have a conversation about changing things up. So I think I'm going to maybe start with David and see if you've got some tips for, either how you approach this or how you try and coax this out of your patients in terms of finding out, if they feel like it's time for a change for something. Because, I want to go back to something that was said very early on about, patients know their bodies best. And so how do you, try and encourage that, potentially, especially at the beginning of your relationship with someone?
Yeah, it's such an important concept, and it's critical to have that dialogue and to have it regularly. I mean, for the diseases that we're talking about, we're really talking about diseases that last a lifetime for most people. And so that journey needs to be one where you critically continue to participate. And ideally, if things are not going well, if your symptoms are plateauing, if you're not experiencing an improvement, if the joints remain continually painful, if it's inhibiting your activities despite your existing treatments, then it's time to have that conversation. What else can we do? And go along and say, I've tried X, Y, and Z as you suggested, and unfortunately it hasn't led to the improvements that you initially suggested it might. Is there anything else that we can try? And what else can we do in this circumstance? And for most healthcare professionals, they want that knowledge, and they want to hear what your experience of treatment is. And more often than not, hopefully, they're also trying to measure your experience and use that as an indicator of the success or otherwise of the treatments that they're advocating that you try. So that's, I guess, broad advice, hopefully not too much specificity, but hopefully something you can use.
Thanks, David. Eileen, would you like to comment?
Yeah, so the medication journey with rheumatoid arthritis is very difficult and very bumpy and can go for a very long time. So I had to try so many different medications when I was first diagnosed, and I'll probably need to try another one or two or here, there. But I've kind of over time developed, and through using Arthritis Research Canada's OPRA's app and a Fitbit, tracking my health taught me a lot about my rheumatoid arthritis and watching for patterns and noticing if my pain is going an increase for more than 3 weeks, or my fatigue or my sleep is decreasing. And if I'm noticing this basically 3 weeks or more of symptoms, that's usually when I bring up to my rheumatologist, do I need a medication change? Do I need to add something? And then I think it's also really important to know that when we start a medication, it's not going to work overnight. It can take 3, 4, 6 months to even kick in. And I think that was probably one of the most difficult, harsh realizations that I had to realize when I was diagnosed with RA is just, how long do you have to try this medication for? And then the other one is knowing that we don't have to go through so many of the unwanted side effects that come with these medications as well. Just telling my rheumatologist, like, I'm losing a lot of hair, or my skin is really itchy, or I'm having really bad stomach pains, meant that I didn't have to go through those and I didn't have to be on those medications. So it's just making sure that you have kind of a document of what you're going through and keep track of what it is and bring that up to your rheumatologist could really make the conversation easier about.
Thanks, Eileen. Either of the two Lindas, would you like to make some comments here?
I would just make a quick comment on patterns is important. I always think of myself as, where am I at now? What have I been doing? And what can I not do now as I'm moving forward? But I'll track that and kind of keep a very, very good eye on it. But I like, personally, from my healthcare practitioners, a stepwise approach. We're going to do this. We're going to do it for this long. This is what we're trying to attain as a goal. And if it doesn't work, here's another step that we can get on. Or here's 2 options that we can do right now. We can either do this one first or this one first, and then explain it, and then have a conversation about that. That works for me. One caveat I want to say too, I think we should clone Dr. David Hunter and use him as a, epitome of a very good example of someone continuing to learn and help us out, and Linda's a physiotherapist. However, what drives me bananas is when I go to a healthcare professional about something, because I have been consulted to go see them because of something that's not getting corrected or getting better. And that person will say the same thing that I just went over for the last 8 weeks or so, and we tried and it didn't make anything better. So I think the caveat is just to understand that the lived experience of the patient going through something, even if that's something you would have suggested, if they've done it already, let's go on to step B, please.
Yeah, and as a physio, and we're obviously not in the realm of like prescribing medication, but I think taking the time to listen to your patients and what's working or not, or I think for me, I spent a lot of time working through the pacing and understanding, helping them, like Eileen say, recognize patterns, like on the days that it's really bad, are there things that are maybe driving it or not? Because sometimes it may be not as clear to the patient. And that's how both of us can work together to recognize where there's something that's potentially kind of contributing to the pain or whatever they're going through. But then again, this is why we need a little bit better of not working in silos and a more interdisciplinary approach, which I think is a big issue for me as a physiotherapist and just a physio clinic right now, is like also the physio now, patient has to be the advocate and you have to be the advocate as well, because in order for you to get information, you're constantly having to talk to so many different people. And that's also a really big barrier to getting timely care, which is a whole nother conversation. But I think, yeah, in the end, we're kind of saying the same message that patients are advocates, physios need to be advocates, or the clinician as well, if we want to kind of make this journey the best it could be.
Thanks very much. Okay, I think we're going to wrap up here, and people have already generously given over our allotted time. I wanted to give our audience a heads up that we are recording this, so you can view your favorite moments at a later date. And I will be recording a podcast also with David on his Joint Action podcast in a couple of weeks to kind of talk about some of the highlights. I hope I do this justice, but we'll kind of do the highlights related to the webinar. So I'm going to pass it over to Carm to thank everyone and wrap up.
Just a 45-second thank you to the participants for making it an invaluable day, and our speakers have got so much to offer, and they've done this in a collaborative way, so we had a good discussion. Thanks for everyone engaging in the discussion and the chat and the Q&A, so engagement there despite our physical barriers, so thanks for all of that. What I heard was that there needs to be the patients do need to have, it's okay for patients to advocate for themselves. So, learn how to do that and be comfortable about it, and own your own advocacy. And the doctors and the clinicians, sorry, I said doctors twice, sorry about that, Linda, and all my physio friends. The clinicians need to listen, but David was using a doctor's voice there and saying that there's, he's not perfect, and maybe a few other doctors aren't perfect and they could do a better job of this listening. I can say that as a doctor. And then the team approach in different ways, like the team, the patient and the clinicians, the shared care model, and then the actual care models with multidisciplinary teams, so that we get wisdom from across a bunch of spaces. But there's a ton more there, and you'll catch more of that from Dawn's highlight video and podcast with David Hunter. So for me, personal thanks to each of you for supporting IMHA as we try to be an ally in moving this field forward for the benefit of patients and helping Canadians and the world have better healthcare and have better health outcomes. Thank you very much.
Thanks, everyone.
Thank you.